Welcome to EKG Monitoring Boxes and Squares. The reference for this presentation is Brady, Paramedic Care, Volume 4, Medicine, Edition 4. But any book that teaches EKG monitoring will have similar information. The conduction system of the heart starts with the sinoatrial node, or the SA node. This electrical signal moves through the intranodal or intraatrial pathways down into the AV node. From the AV node, it moves to the bundle of His and then separates into right and left bundle branches. This electrical signal terminates in the Purkinje fibers that wrap around the right and left ventricle. The conduction system, each step of this conduction system has its own intrinsic heart rate or impulse rate. The SA node will send signals out at 60 to 100 beats a minute. If the SA node does not fire, the intrinsic rate of the AV node will fire at a rate of 40 to 60 beats a minute. If the Purkinje system does not receive any signals from the SA or AV nodes, its intrinsic system will send out beats at 15 or 20 to 40 beats a minute. EKG is basically a graphic record of this heart's electrical activity. Doesn't tell you how well it's beating, it just tells you about the electrical system itself. We get this picture by placing electrodes on our patient's chests or body and looking at it on an EKG monitor screen or graph paper. Positive impulses on the screen or graph paper has a upward deflection. Negative impulses have a downward deflection. The isoelectric line, or flat line, shows an absence of electrical activity. And we can also detect artifact, which is basically a bunch of squiggly lines in between normal electrical conduction. This can be caused by a patient shivering, bumps in the road in the back of an ambulance, and things like that. EKG leads. There are bipolar leads, augmented leads, and precordial leads. The bipolar or limb leads make up Einthoven's triangle. Lead 1 goes from the right arm to the left arm. Lead 2 runs from the right arm to the left leg, and lead 3 moves from the left arm to the left leg. This only shows one view of the heart. Augmented or unipolar leads are AVR, AVL, and AVF, and those can be depicted on our picture also. Precordial leads, V1 through V6, measure cardiac activity in the horizontal axis, and those are otherwise known as a 12 lead. We'll talk more about those later in the presentation. Routine cardiac monitoring only uses one lead, and the most common lead for that monitoring is lead 2. Einthoven's triangle is the basis for lead placement of those electrodes on the patient's heart or body. Please see the picture of 3 leads. You have the white lead, the black lead, and the red lead. White goes on right, the black goes on the left shoulder, and the red goes lower underneath the black. You can remember those placements by salt, pepper, ketchup. Right, left, and below the left for those leads. A 4 lead just adds a green lead to this box to get a picture of the heart. And a memory jogger for a 4 lead is that there is snow on the grass, white goes above the green, and smoke over fire, black goes above the red. So some salt, pepper, ketchup, and snow on the grass, and smoke over fire for memory joggers of lead placements. A single lead monitor can only show you the rate of conduction, the regularity of impulse, and the time intervals of the conduction of those impulses. It cannot show you the presence of any artifacts, axis deviation or chamber enlargement, any differences between right and left conduction, and the quality or the presence of pumping action. So understand that a single lead shows very limited information, but it can show you deadly rhythms. The EKG paper. So the standard speed once you hit print is 25 millimeters a second. The amplitude deflection, 2 large boxes on this EKG paper equals 1 millivolt. 1 millivolt for 2 large boxes. EKG speed needs to be calibrated, and you need to use manufacturer's recommendation to do so. The lines that make up these boxes and squares. The light lines are 1 millimeter, the dark lines are 5 millimeters. And at the top of each EKG paper, you will see 3-second tick marks. One little box represents 0.04 seconds. One big box is 0.20 seconds. 5 big boxes equals 1 second. And 30 big boxes equals a 6-second strip, which you need to estimate heart rate. We can tell where those electrical signals are at in our pathways of our heart by the different waves on our EKG paper. As we said before, the electrical signal starts in the SA node. As it moves through the intranodal or intraatrial pathways and AV junction, it has an upward deflection called the P wave. Then the signal moves through the bundle of His and the bundle branches to the Purkinje fibers. Once the Purkinje fibers get that signal, we have ventricular depolarization, and that is the QRS complex. Then as the ventricles recover, or ventricular repolarization, can be seen as the T wave. The T wave. After the T wave, you may have an upward deflection, a little bump, called a U wave. In some people that's normal, in others it can show signs of injury or other problems. So that's the representation of the P, QRS, and T waves. As you can see, the star is the start of our electrical impulse in the SA node, and that's an isoelectric line. Then it moves through the intranodal or intraatrial pathways, and that deflection starts up for our P wave. As it moves through the atriums to the AV node or junctions, it will complete the P wave. Then we have the PR interval. We have a little delay at the end of the AV junction, and this allows for blood to completely exit the atriums into the ventricles. So the PR interval is a little delay at the end of the AV junction. Then we have ventricular depolarization, showing the QRS complex. The T wave, like we said, represents the ventricular repolarization and recovery from this massive squeeze called the QRS complex. Time intervals on our EKG papers. Normal PR interval is 0.12 to 0.20 seconds. That's the normal PR interval, 0.12 to 0.20, or 3 to 5 little boxes. A normal QRS interval is 0.08 to 0.12 seconds, or 2 to 3 little boxes. The ST segment is the end of ventricular depolarization to the beginning of ventricular repolarization. We can detect problems in this area, and we'll talk about analyzing the ST segment shortly. The QT interval is total ventricular depolarization. QT interval is total ventricular depolarization. When the QT elongates, there's an increased risk of ventricular dysrhythmias or sudden death. Paramedic students, please look at the back of your basic arrhythmia workbook for the rhythm flashcards and start studying those. Refractory periods. The nature of the heart's electrical system, it's an all or nothing process. The absolute refractory period means that from the start of the T through halfway through repolarization, or halfway through the, from the start of the Q wave to halfway through the T wave, doesn't matter how strong an electrical stimulus is, another impulse cannot be conducted. That's the absolute refractory period. No other stimulus can cause depolarization in that absolute refractory period. The relative refractory period means that a strong enough stimulus can cause depolarization once the ventricles are halfway recovered. It's just like our water pump in this picture. We want to get a full load of water or full load of blood out of our pump, being the heart, but we can get a half a load of water when it's halfway down, like our relative refractory period. Hopefully you get that analogy. ST segment changes. ST segment changes can detect ischemia, injury or infarct, and necrosis. If we see ST segment depression or T wave inversion, meaning it's upside down, it means there is some hypoxic heart tissue or ischemia. Then injury or infarct can be detected by ST elevation, and that's as small as one little box elevated above that isoelectric line. And then we can tell necrotic or dead cardiac tissue by a significant or pathological Q wave. The Q wave will be at least one small box wide, if not wider, and at least 1/3 the height of the QRS complex. So if there's dead cardiac tissue or necrosis, the Q wave will be deep and wide. Our lead summary for our 12 lead patients, you see V1 through V6 on the left and right of this matrix. And these are the placements for our precordial leads to get a picture in the horizontal plane. V4 is the primary lead. It is in the 5th intercostal space at the midclavicular line, and that is the apex of the heart. If you go up 1 intercostal space, you'll be in the 4th intercostal space, and you'll move to the left sternal border and place V2. Then you'll scoot on over to the right sternal border, 4th intercostal space, for V1, and then you'll place V3 in between V2 and V4. The next electrode to place is V6, and that goes on the mid-axillary line at the level of V4, and V5 goes in between V4 and V6 on the anterior axillary line. And then you see our matrix in the middle of the screen. Leads 1, 2, 3, AVR, AVL, and AVF, and then V1, 2, 3, 4, and 5. V, 2, 3, and AVF show the inferior portion of the heart and the right coronary artery. That is 2, 3, and AVF. V1 and V2 shows the septum, the ventricular septum, which separates the right and left ventricles, and that's the left coronary artery anterior descending branch for V1 and V2. V3 and V4 show the anterior portion of the heart, which is supplied by the right coronary artery, and the lateral portion of the heart can be seen in V5 and V6, and that's a left coronary artery circumflex branch. A memory jogger to remember these is I see all leads. 2, 3, and AVF is I for inferior. V1 and V2 is C for septal. V3 and V4 is all for anterior, and V5 and V6 is leads for the lateral aspect. I see all leads for our 12 lead representation. Interpretation of these rhythm strips. Any book that teaches you rhythm interpretation tells you to memorize the rules for each rhythm. Memorize the rules for each rhythm. We will teach you the 5+3 step process for rhythm interpretation. The 5-step process, you're going to analyze the rate, the rhythm, the P waves, the PR interval, and the QRS complex. And then the +3 is analyzing the ST segment and the Q wave. We're looking for ST segment depression or T wave inversion, elevation of that ST segment, or looking for that pathological Q wave, wider than one little box and at least 1/3 the height of the QRS complex. Analyze the rate. The first two methods are the 6-second method and the heart rate calculator. As I mentioned prior to, our EKG strips have black tick marks at the top of the page in 3-second intervals. You need to see 3 of those tick marks to get a 6-second strip. 6 times 10 equals 60, and there's 60 seconds in a minute. So if you count QRS complexes, this strip has 9 of those, which would mean the heart rate is 90. So that's the 6-second method. Then there's the heart rate calculator or ruler, and the best thing to do is read the directions on the various rulers and use them how they tell you to. Two other methods to analyze rates are the R to R and the triplicate. Both of these methods are only accurate when the rhythm is regular. With the R to R interval, you're going to start at 1 R and count the little boxes to determine the time in seconds. Then you're going to divide that time by seconds, or by 60, and it'll give you the rate. So the time interval in seconds between the R's divided by 60, and that'll give you the rate. And we'll practice those in lab. The triplicate method, you have to find an R that falls on a solid dark line, and then each subsequent dark line goes down from 300 to 150 to 100 to 75 to 60 to 50. If you notice on the rhythm strip on this slide, there's one R wave right on a black dark line. So the next box to the right would represent a rate of 300. The second line to the right would represent a rate of 150. The third line would represent a rate of 100. And then right after that third line, you'll see another R wave in a QRS complex. So we know our heart rate is less than a 100 and somewhere in between 100 and 150. Triplicate method's not extremely accurate, but it'll get you in the ballpark. Analyzing the rhythm. You're going to get some calipers out and analyze your R to R intervals. Analyze your R to R intervals. And if they fall at regular intervals, then the rhythm is regular. So things can happen like PVCs or PACs, or funny little beats that cause a rhythm to be occasionally irregular. Then some rhythms can be regularly irregular with those various beats, or rhythms can be irregularly irregular. The only rhythm that is irregularly irregular is atrial fibrillation. Analyzing P waves. There are 5 different things to look at when you're analyzing P waves. Are the P waves present? Are they regular? Is there one P wave for each QRS complex? Are the P waves upright or inverted? And do they all look alike? The 5 things to analyze when looking at a P wave. Next, we'll analyze the PR interval. And a normal PR interval is 0.12 to 0.20 seconds. If it's outside of that range, then it's abnormal. Then we analyze the QRS complex. As stated previously, the normal QRS complex is 0.08 to 0.12 seconds, or 2 to 3 little boxes. And that completes the 5-step rhythm recognition process that we'll practice to begin with. Once we get into 12-lead interpretation, we'll do the 5 plus 3 completely. Rules apply to a regular sinus or a normal sinus rhythms are this. The rate is between 60 to 100. The rhythm is regular. The P waves are present. Interval is regular. They're upright. There's one for each QRS, and they all look alike. The PR interval is 0.12 to 0.20, and the QRS complex duration is less than 0.12 seconds. And that rhythm looks like this, which is a normal sinus rhythm. And how you apply the 5-step rhythm recognition process. That concludes our presentation for today. If you have any questions, by all means, bring them to class. Thank you.